without any further ado, because we have a very busy schedule, I'm very happy to introduce myself. My name is Gilberto Lopes. I'm a medical oncologist at the Sylvester Comprehensive Cancer Center in Miami, and I have several colleagues with me today. I have Dr. Jorge Antunes, who is our co-chair for this event, and he's going to be coming up to the table at the end of the first session, which is lung cancer. He is an assistant professor of clinical medicine and associate director for CME at our institution, and I have the pleasure to introduce our two speakers for the lung cancer for the thoracic oncology session, and these are Dr. Emeka Ikpeazu and Dr. Stella Maris Rodriguez. We'll ask Dr. Ikpeazu to come onto the podium. Let me see if I have a slide so that I don't mess your titles. That is me. That's a relatively new picture. I'm bald. That's been there since high school, so. And just before we start, here are virtual instructions on how to submit questions and how to expand your video screen. Practicing healthcare providers should click on the Ask a Question button, and that's on the left-hand side of your screen. You type in your question, and then you just click Submit. We will try to get to as many of those questions as we can today, and we'll try to answer some of those remotely if we don't get to them. To expand the video player to full screen, you should click on the icon on the lower right-hand corner of the player. Hit Escape on their keyboard if you want to go back to the smaller player. So I think that those are the main housekeeping instructions, except that if you are here, please do reach to the microphone. You remember what those are. That's the little pole thing. You go there, you tap. We can make sure the mic is working, and you just ask your question as we used to do, because we are old. Today, kids actually do that by TikTok, I guess. Dr. Ikpeazu, please, we're all yours.
Thank you. So welcome to the new year of oncology, and welcome to our update 2022. So I will have the pleasure to talk to you about updates in small cell lung cancer today, if I can get this thing to work. The green button? Oh, there we are. Very good. Good morning. So yes, I have the pleasure of speaking with you today we're going to be speaking about small cell lung cancer, which accounts for about 15% of all your lung cancers. And specifically, I will be talking about updates in extensive stage disease. Extensive stage small cell accounts for about 2/3 of all your small cell lung cancers. And the 5-year overall survival for small cell lung cancer is about 7%. In fact, over the past 30 years, platinum etoposide, or EP, has been the standard of care in the first-line setting over the past 30 years. Atezolizumab or durvalumab, both of which are PD-L1 inhibitors in combination with EP, was recently or relatively recently approved by the FDA as first-line treatment in this setting. However, the PD-L1 inhibitors, these agents can only prolong survival, you will find out, by about two months. So moreover, the efficacy of PD-1 inhibitors in this space remains unclear. You are familiar with IMpower 133, which was a randomized double-blind placebo-controlled study evaluating atezolizumab with etoposide in the first-line disease setting. This study randomized patients 1-to-1 to receive atezolizumab plus EP versus placebo plus EP times 4 cycles, followed by either atezo maintenance in the atezo arm or placebo maintenance in the placebo arm until disease progression or intolerable toxicity. The co-primary endpoints in the study were overall survival and PFS as assessed by investigator. And these are the Kaplan-Meier plots for the overall survival as well as progression-free survival. And if I can see clearly, you will see that the median overall survival in the experimental arm was, I believe, 12.3 months, and in the control arm was 10.3 months, and in favor of atezo arm, and the progression-free survival in the experimental arm was 5.2 compared to 4.3 in the control arm. Now, when you look at the subgroup analysis in the forest plot, you will also see that the addition of atezolizumab actually favored most, if not all, the subgroups analyzed. Now if you carefully look at the forest plot, you will see that the addition of atezolizumab, or the efficacy of atezo in this space, was not impacted by tumor mutation burden. So, which a lot of us found very interesting. Now, so the conclusion from the study is that the addition of atezo to chemo, that is EP, in the first-line setting in extensive stage disease resulted in significantly longer overall survival and progression-free survival than chemotherapy alone. Now, this is the Kaplan-Meier for overall survival and progression-free survival in the PD-L1 subgroup analysis. And if you look at this curve carefully, you will see that the PD-L1 was not impacted by the efficacy of atezolizumab, and as well as the progression-free survival. And when you look down the forest plot, you will also notice that the impact of atezolizumab was not preferentially affected by PD-L1 status. So it appears that atezo, in combination with chemo, was not influenced or preferentially impacted by biomarkers. So the conclusion, too, was that the addition of atezo to EP as first-line treatment for extensive stage disease continued to demonstrate improved overall survival, tolerability profile, the updated analysis confirming the regimen as a new standard of care, and that exploratory analysis demonstrated treatment benefit independent of PD-L1 status or TMB status. So then there was the Caspian study, which was presented 2 years ago at ASCO. A phase 3 randomized open-label control multi-center study in which patients were randomized 1:1:1 to receive durvalumab, a PD-L1 inhibitor, plus tremelimumab, a CTLA inhibitor, plus EP times 4 cycles followed by durva maintenance, or durvalumab plus EP times 4 cycles followed by durva maintenance, or EP times 6 cycles followed by optional PCI. So again, you look at the survival curves, the overall survival and the progression-free survival, and you will see that the overall survival the overall survival actually was in favor of the experimental arm with a median overall survival, I believe, of 13 months compared to 10.3 months in the control arm. And the progression-free survival in the experimental arm was, I believe, 5.3 compared to 4.6 in the control arm. And if you also look at the forest plot subgroup analysis, you will see that durvalumab, addition of durvalumab to EP favored all the subgroups that were analyzed. So the conclusion was that first-line durvalumab plus EP significantly improved overall survival in patients with extensive stage small cell versus chemotherapy alone. And the safety findings were consistent with known safety profiles of all the drugs studied. So then came in recently, last year, the ESMO Congress presented a 3-year overall survival update of the Caspian study. And you see that even after a 39.4 months median follow-up, the efficacy of Duva was sustained and maintained. After 39.4 months, the median overall survival still remained at 13 months for the experimental arm and 10.5 months for the chemotherapy arm. And the 36-month survival rate was 17.6% for the experimental arm and 5.8% for the control arm. I kind of like looking at it, so it's bigger. But anyway, so again, if you look at the 3-year overall survival forest plot, it was in favor of the durvalumab arm, and all the subgroups analyzed were positively impacted. So the conclusions were that this updated overall survival analysis from the Caspian study has the longest median follow-up reported to date for a phase 3 trial of EP plus anti-PD-L1 inhibitors in patients with extensive stage disease, and that Duva plus EP demonstrated sustained overall survival benefit over EP with a well-tolerated toxicity profile after over 3 years of median follow-up, consistent with the previous analysis. And also 3 times more patients were estimated to be alive at 3 years when treated with durvalumab and EP versus EP alone, with majority of the patients still receiving durvalumab maintenance treatment at data cutoff for establishing durvalumab plus platinum etoposide as standard of care in the first-line setting. So this table sort of gives you a comparative analysis of these 2 regimens, the Empower 133 regimen and the Caspian regimen. The median follow-up in the Empower regimen was 22.9 months and 39.4 months for the Caspian. The median overall survival is shown in the table. And of course, as you know, both agents have been approved in the first-line setting in this space. The Empower regimen was approved in March of 2019, and the Caspian regimen was approved exactly a year later. Now, at ASCO this year was presented the Skyscraper 02, which was a phase 3 randomized double-blind placebo-controlled study of atezolizumab plus carboplatin with or without tiragolumab in patients with extensive stage disease in the first-line setting. Background. So based on the results of Empower 133, atezolizumab in combination with carboplatin is the current standard of care for untreated extensive stage small cell lung cancer. However, most patients eventually experience disease progression, and there is still significant unmet need for the new therapy options to improve long-term outcomes. TIGIT is a novel inhibitory immune checkpoint present on immune cells in many cancers, including small cell lung cancer, and TIGIT expression is highly correlated with PD-1 expression. Tiragolumab is a human anti-TIGIT monoclonal antibody that may synergize with other immunotherapies, such as PD-L1 inhibitor atezolizumab, to amplify the anti-tumor immune repertoire. Skyscraper 02 is a randomized phase 3 trial of tiragolumab versus placebo in combination with atezo plus EP as first-line therapy in extensive stage small cell lung cancers, including those with or without brain metastases. This is the study scheme. Patients were randomized 1-to-1 to receive tiragolumab plus atezolizumab plus EP times 4 cycles, followed by tiragolumab and atezo maintenance, or placebo plus atezo plus EP times 4 cycles, followed by placebo and atezo maintenance. Co-primary endpoints were overall survival and as well as a PFS by investigator-assessed assessment in the primary analysis set. Now, the primary analysis set were patients without brain metastases. Now, again, you will see in this study that in the primary analysis set, patients without brain metastases, the median overall survival was 5.4 months in the experimental arm and 5.6 months in the control arm. The interim overall survival in the primary analysis set, again, these are patients without brain mets. The median overall survival in the experimental arm was 13.6 months and 13.6 months in the control arm. In the full analysis set, these are all the patients with or without brain mets. Again, you will see that there really was no difference in terms of the progression-free survival or overall survival. The progression-free survival for the experimental arm was 5.1 months and 5.4 for the control arm. In overall survival, the experimental arm was 13.1 and 12.9 in the control. Now, if you look at a subgroup analysis of overall survival in the forest plot, you will see that the addition of tiragolumab really did not impact any of the subgroups that we analyzed. And again, these are the overall survival subgroup of patients with brain mets, and the survival was not really impacted by the addition of tiragolumab. The experimental arm was 11.7, and the control arm was 10.64 months. So the conclusions were that the addition of tiragolumab to atezo plus chemotherapy did not provide further benefit over atezo plus chemotherapy in patients with untreated small cell lung cancer, extensive stage small cell lung cancer. No difference in progression-free survival or overall survival was observed between treatment arms in the primary analysis set or in the full analysis set. Tiragolumab plus atezo plus chemo was well tolerated. The safety profile was similar to that of atezo plus chemo and was consistent with previous observations for this combination. There were no new safety signals identified. The progression-free survival and the OS observed in the control arm, placebo plus atezo plus chemo, support the results observed in IMPOWER 133 trial and further confirms this combination as standard of care in patients with extensive stage disease in the first-line setting. Skyscraper-02 study will continue to the planned primary OS analysis and biomarker analysis are currently ongoing. So based on this data, targeting TIGIT in extensive stage small cell lung cancer does not appear to be therapeutically relevant. Investigation of tiragolumab is ongoing in the non-small cell lung cancer space and other tumor types, including esophageal cancer. Now, also presented at ASCO a few weeks ago was ASTROM 005 study. This was a randomized, double-blind, multicenter, placebo-controlled phase 3 trial. Patients were randomized to receive seplilumab plus carboplatin times 4 cycles, followed by seplilumab maintenance, or placebo plus EP times 4 cycles, followed by placebo maintenance. Primary endpoint, overall survival. So, as there still exists huge unmet medical needs, more beneficial immunotherapies needed to be explored to further support the applications of checkpoint inhibition in this small cell lung cancer space. Seplilumab, which is the first PD-1 that has made it this far, the first PD-1 inhibitor, keeping in mind that Duva is a PD-L1 inhibitor, atezo is also a PD-L1 inhibitor, showed excellent anti-tumor activity with a manageable safety profile in the pivotal study ASTROM 010 and was approved for the treatment of MS-high solid tumor patients by the China National Medical Product Administration in March of this year. So this is the overall survival curve of ASTROM 005. You will see that in the experimental arm, the median overall survival was 15.4 months versus 11 months in the control. And the 2-year survival rate was 43.1 in the experimental arm and 7.9 in the control. Now, the forest plot overall survival in all the subgroups analyzed basically favored the experimental arm. And if you look at the progression-free survival, the experimental arm had 5.7 months median progression-free survival compared to 4.3 months. So the conclusions were that seplilumab plus chemo showed consistent benefits of OS, PFS, ORR, and DOR, and long-term efficacy benefits were also observed. Median overall survival in the experimental arm, 5.4 versus 10.9 or 11 months, if you want to be nice. And the median progression-free survival, 5.7 versus 4.3 months. Seplilumab plus chemotherapy showed manageable safety profile, no new safety signals observed, and the orphan drug designation of seplilumab in small cell lung cancer has been granted by the FDA, and the NDA of seplilumab in extensive stage small cell lung cancer is under review by the China National Medical Product Administration. So these are the 4 studies we just talked about. And as I mentioned, Skyscraper-02 was a negative study. So that leaves you with the ASTROM 005, Caspian, and Caspian study, and the IMPOWER 133. So my suspicion is that the ASTROM regimen will be approved by the FDA very, very soon. So the decision then for us will be, what regimen do you want to treat your patients with? And I suspect that our decision will have to be dependent on how much you want to pay for 2 or 3 years of survival prolongation. So basically, what this is telling us is that over the last 30 years, all we've been able to achieve in the small cell lung cancer space is prolonged survival by an average of 3 months. That is precisely why I have this snail here. Research in this space has been snail-paced. And my colleague, Dr. Estela Rodrigo, will be talking about non-small cell. And over the last 10 years, I think, in my opinion, non-small cell lung cancer has had the most progress compared to any other malignancy. Thank you very much.
Thank you and good morning, and thank you for that introduction. So yes, I will cover non-small cell lung cancer, which has definitely more data, more drugs and approvals, but it wasn't always the case. So I will show you some of my disclosures. So when I completed fellowships, and I'm not gonna tell you my age, this is how the landscape of lung cancer looked. We only had platinum-based chemotherapy to offer patients. I remember we got very excited about the addition of bevacizumab when we first had a median survival over 12 months. But the majority of patients either had erlotinib based on a trial called BR21 from Canada, where patients without being specified by mutation had erlotinib. And I remember my attending was like, patients with lung cancer, if they fail chemo, it's either hospice or you try erlotinib in the chance that they may respond. Now, we obviously now know that we need to do proper NGS testing and select patients that will be candidates for the proper targeted therapy. So the landscape is like Brickell Avenue in Miami. It's completely transformed, more expensive, but we definitely have more drugs for patients. We have chemoimmunotherapy, immunotherapy, monotherapy, and several targeted therapies, like Dr. Piazza mentioned, that have really become available in the last 10 years. So 35% of patients with advanced lung cancer have a driver mutation that is targetable. So this is our job to make sure that we identify these patients from the beginning, and there are several data sets that have shown us that we don't do that well. So last year they presented data at ASCO from the US Oncology database that about half the patients don't get proper testing through the nation. Flatiron data also has shown the same. And about, for example, for ALK, 54% of patients may start first-line treatment without having the ALK identified. So finding the patients and offering them the proper target really will allow us to do better for patients. So lung cancer is really the poster child of precision medicine and immunotherapy, and you can see that most of the approvals for all of this science has been in the last 10 to 20 years. And really in the last year alone, we have had treatments for patients that we couldn't, do we have I can't point here. Sorry. Yeah, we had treatments that we didn't have before. So for example, I will mention sotorasib. It's a KRAS G12C therapy that was not available, and it's a very common mutation. So that became available last year. We have two EGFR exon 20 treatments. One is IV, and one is an oral drug. And again, things that were not available. And I think in the last 6 months, we really have, several months, really have moved immunotherapy up front in neoadjuvant and adjuvant settings and trying to find better responses for patients. So this is all good news for patients, and I will cover some of our abstracts that have been presented that cover the neoadjuvant setting, the adjuvant setting, some highlights from stage 4 and targeted therapy. So first I will cover immunotherapy in early stage lung cancer, which is, if we have seen success in the metastatic setting, how do we move these drugs up front, potentially before patients get very sick and potentially prevent progression. And I think the beauty of immunotherapy is that you're building this immune response to cancer and potentially could have more long-lasting potential cures. So CheckMate A16, it was a trial that was presented at the prior ASCO, and it's really a trial that has gotten a lot of attention. It got approved in March of this year, and our surgeons at the University of Miami are really starting all the conversations with patients that have stage 2 and stage 3 disease. Is this patient a potential candidate for neoadjuvant chemoimmunotherapy? So I will describe this trial because we had additional data from Spain that confirmed this approach. So this is a trial where patients had only 3 cycles of chemo IO right before surgery, and within 6 weeks of finishing that chemo IO, they were taken to surgery. And what really was very impressive was we don't have yet overall survival, but we did have a very dramatic improvement in pathologic complete response. So you saw that just before surgery, if you look at the time people have their pathology, you only get about 2% pathologic complete responses from chemo alone. And then if you add immunotherapy, that goes up almost tenfold. And this has been shown to be the case for all stages and regardless of PD-L1. So we saw data at ASCO this year, an updated analysis of the NADIM-2 trial, which was a different chemotherapy that they used. They used carboplatin Taxol with nivolumab, and they also did 3 cycles of therapy. In the prior treatment, after surgery, you had the option of adding more immunotherapy or adding radiation. In this trial, they actually added immunotherapy for the patients for 6 months. So that's a little bit different. This is experimental design. Patients had nivolumab, paclitaxel, and Taxol, paclitaxel and carbo for 3 cycles right before surgery. And they showed the same thing, and they have follow-up data that we don't have for the CheckMate A16 trial. The adjuvant treatment included 6 months of nivolumab. And here was even more impressive. The pathologic complete response rate was 36% versus 6% for chemo. So I think one thing to highlight here, not only that you can increase the pathologic complete response rate, but perhaps carbotaxol, the way it's given in Spain, gets you a better chemo response at the time of surgery. And this is an interesting question, is carbotaxol a better partner for this immunotherapy combination? The one thing that I've seen in our practice, and especially in settings where patients don't have access to surgeons, that if you have a patient that is potentially a surgical candidate, starting chemoimmunotherapy from the get-go may allow that patient to have time to meet the surgeon and get going, and hopefully by the time they have surgery, you could have such a dramatic complete response. I do want to highlight that in both of these trials, they excluded patients with EGFR and ALK mutations, because we know those patients either can have or have a completely different disease, and they may not respond, obviously, to immunotherapy, and that has been seen in other trials. So that goes to show that we will have to test for those patients up front. Now, I'll move now to the adjuvant space. So these are patients, the ones we cover, that haven't had surgery, they haven't met a surgeon yet, or they're working in a multidisciplinary team. There are patients that we meet after surgery, and the Empower 10 trial was presented last ASCO and also approved later on, and it included patients that had stage 1B more than 4 centimeters and had completed chemo. So these patients already had made it through a big hurdle of chemo, and then they were randomized to immunotherapy for a year or observation. And we saw that most of the patients in the trial have stage 2 and 3 disease. There was a smaller group, 12%, that has stage 1B. They did include patients with EGFR and ALK in this trial. And this is the results. All patients in the intention to treat analysis had an advantage if they had received immunotherapy in the adjuvant setting, and this was approved by disease-free survival, not overall survival. So you see that in all the randomized stage 2 and 3, the median overall survival was 42 versus 35 months. So again, we see a very difference early on the survival of patients, at least the disease-free survival of patients after surgery when they receive immunotherapy. This was approved for patients that had PD-L1 expression, where the differences were more robust, and it was approved for stage 2 and 3. So stage 1Bs, not a big difference, and PD-L1 negative, not candidates for this adjuvant approach. So if you want to offer people with adjuvant immunotherapy in the early stage disease, the neoadjuvant setting gives you the opportunity of offering it to all comers, regardless of PD-L1, because they did see responses, but it's a whole different scenario. Now, there is additional data. So people ask, what about pembrolizumab that is used widely for metastatic disease? What is the data for pembrolizumab in the adjuvant setting? So there was an update from the Pearl's Keynote 91 study. And I guess I always get suspect when trials are lagging behind in presentation, like what was happening with this trial. But it was a trial very similar to the Empower 10 data. They had patients that had surgery, stage 1B to 3A. They had baseline PD-L1 testing. They had completed chemo, and then randomized to a year of pembrolizumab. And the endpoints were very similar, disease-free survival. I will tell you that most of the patients had received adjuvant chemo. There was a group that about 15% of patients who hadn't finished the chemo and went to immunotherapy. They also included EGFR and ALK patients. And these are the responses that were presented at this ASCO. So there is, in the green line, you do see some, I can figure this out, okay. You do see that the pembrolizumab arm, at least for the disease-free survival, was higher. But then down here in the smaller subset, they saw something really interesting, that the PD-L1 less than 1 had a hazard ratio of 0.78, And the PD-L1 that was higher than that, the more than 50%, had a hazard ratio of 0.82. So that it seemed like the low PD-L1 was getting more advantage than the high PD-L1, which is not usually the case. So the only way that they can explain this is that it's an interim analysis, and more data will really show if that will pan out. But this is probably will be the next immunotherapy that will be approved in the adjuvant setting. Now, I will move to metastatic lung cancer. Just to kind of give you an update, we have a lot of immunotherapies in the space, and Dr. Ipiasu talked about immunotherapy in small cell lung cancer that has shown a marginal benefit. In non-small cell lung cancer, there is definitely a greater benefit. Hazard ratios are between 0.49 in the Keynote 189 trial for non-squamous, 0.7, 0.64 for the squamous group. So there's an advantage to immunotherapy, either with chemotherapy, as a monotherapy if you have high expression. We have data for double checkpoint inhibitors by themselves, Checkmate 227. We have Checkmate 9LA that has 2 cycles of carbotaxol with a double checkpoint inhibitor. And all of these strategies can get you an improvement in survival. So I don't think any patient today with metastatic disease in this country would really, should be really, if they're a candidate for treatment, they will receive immunotherapy up front. But it's very important that you identify, again, the patients with targetable mutations, because they will do better with that targetable treatment than immunotherapy. And monotherapy data, the newcomer on the group is cemiplimab, that was approved in February of last year in the Empower Lung 1 data. It has a very impressive hazard ratio of 0.54. They have shown their data for very high PD-L1 expression with better improvements in survival, and they also have shown CNS activity. So again, we have a lot of drugs. I think people have gotten used to using the one that they started using from the beginning, but there are different scenarios where you can think of patients that will benefit from all of these drugs. Hopefully this competition would also change the cost of these drugs. So this is today our algorithm, and obviously the science for non-small cell lung cancer has changed very rapidly, but still to this day, if you have an oncogenic driver, that's the first thing you have to answer. We do reflex testing for PD-L1, so when we do a biopsy of a new case of lung cancer, we will understand the PD-L1 status. If the patients have high PD-L1 and they have no oncogenic driver, so if they fall on this group, we will offer immunotherapy alone. There are some exceptions. Patients that are young, have very rapid burden of the rapidly growing disease. Sometimes you don't see a response for immunotherapy. This is a group of patients that I have actually used the Checkmate 9LA protocol or some of the double checkpoint inhibitors. For PD-L1, kind of in between, either low or more than 1%. So for more than 1%, you can use chemo-IO. For less than 1%, you will use chemo-IO. And for immunotherapy, you also have data that Dr. Lopes presented years back on ASCO. So what happens after you had immunotherapy progression? And now I started talking about using immunotherapy really early on in the neoadjuvant setting and the adjuvant setting. So now all these patients are seeing immunotherapy and they progress either after stage 3 therapy, the Pacific protocol with durvalumab, or now the Checkmate A16 nivolumab in the neoadjuvant setting, and now metastatic disease. So this is really the challenge for us in clinic, and one trial that really got a lot of attention came from the LungMap protocol. So the LungMap protocol is a very interesting approach. It's a basket trial that was organized by SWAG, and they basically took patients that have failed, that needed second-line therapy for lung cancer. And this is one of the subset studies that was presented by Dr. Reckamp. And it was a phase 2 randomized trial of ramucirumab plus pembrolizumab versus standard of care for patients that have progressed on immunotherapy. And they were this was 130 patients that were randomized. Key eligibility I will highlight was that patients had to have therapy had failed therapy within 3 months. So they have to at least respond there for 3 months before they were randomized. So these are not for very rapid progressors, at least 3 months. But that 3 months is still reasonable. All patients had to be candidates for ramucirumab, and they concentrated on better performance status. And then patients were randomized to investigator choice, but most patients, they get docetaxel ramucirumab, which is the currently go-to combination in the second-line setting, and then patients were randomized to pembro and ramucirumab. And there is data for the effect of angiogenesis in modulating the immune system. We know that it can lead to immune proliferation and function of the T cells, high PD-L1 expression. You have indirect effects on the endothelium that would allow the immunotherapy response to be more effective. You also have indirect physical effects from hypoxia leading to immune cell infiltration. So there seems to be an opportunity to really kind of wake up the immune response again. And these are the results. These are patients that had failed immunotherapy, and the only option that we have for them is chemo. And now we have one phase 2 data, so this has to be confirmed in a larger trial, that showed an improvement in survival. So there was an improvement of about 3 months for patients that received the combination of immunotherapy with ramucirumab. So the beauty about this, and I think some of the overall survival advantage, is that you're comparing people that had chemo when they are progressing and they're sick to people that are still staying on treatments that are not as toxic, like pembrolizumab and ramucirumab alone. The hazard ratio was 0.69. The interesting thing also that they found is that the progression-free survival was actually inferior for the experimental arm, so that the progression-free survival for the patients that had the standard of care was slightly greater, 5.2 versus 4.5 months. And this has been seen in other immunotherapy trials, that the progression-free survival doesn't match the overall survival. But when they did subgroup analysis of performance status, different biomarkers, PD-L1 expression, most of this favor the treatment arm. And I think this is the message for me, that if you had a patient who had failed immunotherapy and now your option is to move to chemo, and chemos that have very limited responses, around 28% on average. You will get immunotherapy with ramucirumab, and still the responses are not that great, but the stable disease is greater. And we have seen this when we have treated people with immunotherapy beyond progression, that we have patients that are slowly progressing, and if you keep them a little bit longer, they will get a benefit and they do better overall. And this is that concept, but with ramucirumab making it kind of boosting the response. So the duration of response was very different, 12 months versus 5 months for chemo versus immunotherapy and ramucirumab. Another message that I got from ASCO is really all of the newer data that's coming out on the brain activity of immunotherapy. So this is an updated analysis of the Atezo brain trial was presented by Ernest Nadal from Spain. And it was a trial that was devised to look at the question of, if we enroll patients with brain mets at baseline on immunotherapy without doing radiation, how do they do overall? And there were 40 patients, so not a very large group, but this is a very well-designed trial. Patients had to have no rapidly active neurological symptoms. They could be on low-dose dexamethasone, less than 4 milligrams a day, and no leptomeningeal carcinomatosis. These patients were randomized to the standard chemo-IO with pemetrexed Atezo every 3 weeks, and then they were monitoring the brain every 6 weeks. And these were patients that had significant burden of brain disease. They had a total of brain lesions on average was 5 up to 20. A lot of them had synchronous brain mets, about 93%. And there was a whole range of PD-L1 expression, patients included. And this, I think, really got my attention, that if you have patients with brain mets and they are coming to you and you're going to delay their systemic treatment, this data supports not doing that you can actually start them on systemic treatment and you'll be able to get some intracranial activity. So the systemic, and the one thing that they saw is also there was the intracranial response followed the systemic response. So if patients were responding systemically, they were also responding in the brain. The 12-week progression-free survival was 62%. The median intracranial progression-free survival is 6.9%. And I think the message being here that brain mets at baseline are a poor prognostic indicator. And in this small trial, almost a third of patients were alive at 2 years, so that you do get some control of disease in the brain. These patients did get radiation, but having had systemic chemo-IO delayed the use of radiation and potentially the toxicity to the brain. Now, the last section, really quickly, is targeted therapies, and there are too many targeted therapies for me to cover, but I will cover only the one that was in the New England Journal that same weekend of ASCO, and you know that when they release data and they have an article, it's something to note. So this had to do with KRAS G12C, which we know is a very common, actually the more common mutation in lung cancer, very aggressive, and 13% of these KRAS mutations are G12C. We know from last year data looking at sotorasib that this functions as a molecular switch on and off, and sotorasib and adagrasib, which is the newer kid on the block, forms this irreversible bond with the KRAS G12C and holds the protein in an inactive form. And this protein is constantly regenerating, so that's why this drug has to be given daily, because you will lose the effect. So the Crystal-1 data was presented by Dr. Spira. It kind of presented the overall safety and activity of adagrasib, and that was published in the New England Journal. It was patients that had KRAS G12C mutation that have failed prior chemo IO, so they have to all have had chemo or IO, either concurrent or sequential, and they followed them. The dose of adagrasib is twice a day, 600 milligrams. And this was a patient group very similar to the sotorasib data. These patients are sick. When they present, 40% of them have bone mets, 21% of them have brain mets, and really a lot of burden of disease. A lot of these patients were heavily pretreated. And this is mostly in a North American cohort. And you can see here from the water plot that most patients did get a partial response, stable disease. The overall responses were 43%, and there were deep responses that stayed with patients. The median overall survival, 12.6 months, and the progression-free survival, 6.5 months. And these are patients with aggressive disease. They also saw activity in the brain, which was of note because these drugs necessarily don't penetrate the brain very well, and the same mechanism that gets them in the brain gets them out of the brain. But the fact that they saw activity was of note. They see stable disease and partial responses, meaning that the blood-brain barrier is really not that perfect in patients with advanced disease. I would just comment on the adverse toxicity. So they did see a lot of grade 3 and 4 adverse toxicity. Most of it was GI. And LFT abnormalities, but the discontinuation rate was 7%. So again, it's another drug that we're learning to use. We have to learn to manage and adjust so that patients can stay on treatment and get that benefit that is close to a year. And I will compare that to the sotorasib data presented a year prior, very similar, and they have updated their North American subgroup, median survival 13 months, progression-free survival 7 months with a lot of stable disease. And the toxicity, again, a little bit less with cut break and some GI fatigue. The dosing for the sotorasib is 920 milligrams once a day, but patients have to take 8 pills in the morning. So the amount of pills and how often you take it may make a difference when you select these drugs. So in conclusion, neoadjuvant immunotherapy and adjuvant immunotherapy can improve outcomes in early stage disease. The standard of care for advanced lung cancer remains chemo IO if you don't have a targeted option or immunotherapy alone. Pembrolizumab looks as a very good option, and we need to see more data for post-IO progression. And obviously, if you have an oncogenic driver, even KRAS G12C, you will do better with that target. Thank you.
Thank you very much, Emeka and Stella Mari. We don't have any online questions at this time. Is there any question from the audience? All right. So, Emeka, I noticed in one of the trials that you presented that one of the, on the control arms, they actually included PCI for the chemo arm, whereas that was not included on the experimental arm with immunotherapy. Can you comment on the effect on small cell lung cancer and on brain metastases with the immunotherapy?
If you look at I believe that was there was Empower 133 and also the Caspian. The Caspian looked at the effect on brain, and there was no difference with IO in the primary analysis set, which were those patients without brain mets, and in the final analysis set, which were patients with and without brain mets, so all the patients combined. There really was no subgroup difference in this group. So What does that say? It probably suggests that IO in the small cell space is really not, does not positively impact patients with brain metastases, at least in the small cell space.
Okay. Stella Marie, regarding the use of immunotherapy on brain metastases, has that changed your practice? Are you now treating your patients with brain mets straight out with immunotherapy-based treatments?
Yeah, I guess I will say that we sometimes as medical oncologists meet patients after they went to the hospital with brain mets, so they already have been treated. But I think the message here is that we need to kind of be more conservative. Our team, our radiation oncology team, is conservative. For example, patients with ALK mutations today have drugs that give you a 90% improvement in survival in the brain, like lorlatinib. So those patients shouldn't be getting radiation up front. And also now with immunotherapy, if you're asymptomatic and how comfortable you feel with this asymptomatic concept, patients can respond systemically and in the brain at the same time. So we can, as we treat patients, and I think the big message for lung cancer in the last 10 years is that patients are living longer. And as you see people living longer, then you see the toxicity of radiation. I mean, we have all the time, Dr. Ipiazzo can tell you, patients that come in with radiation necrosis. Like now, the treatment caused something that impacted their quality of life years later. So patients are surviving, and if we can kind of decrease the toxicity from the radiation to the brain, that would be key.
Yeah. Now, I'm going to jump ahead in a way, to something that happens in GU oncology when you use neoadjuvant chemotherapy. You have your patients with locally advanced bladder cancer. You treat them with neoadjuvant chemotherapy. The tumor goes away, and the patient goes away. Okay. Yeah. So, is that happening with neoadjuvant chemoimmunotherapy now that we're achieving such a high CR?
So you mean like the patients get toxicity?
The patients refuse to have surgery. That's one of the problems that we face in bladder cancer.
Oh, that's interesting.
Is that happening now that we are this is a standard for the last 2 years now?
Yeah, I mean, I guess the pathologic complete responses and the imaging doesn't really change that dramatically for people not to have surgery from a cancer that is so aggressive. So I don't think what has happened is that although most of this data has shown that patients did have planned surgery and very few patients were not taken to surgery, these trials are very selective patients. We did the Checkmate A116. We enrolled a few patients. They were very selective patients. They were patients who the surgeon felt that they could tolerate the chemo IO, and we have tried to use that same approach for elderly patients, and I have seen several that have not made it to surgery, like they got sick from the treatment. So I think that patients are not declining surgery, but patients are getting sick in the neoadjuvant setting, and that's of concern because there are patients that you could have taken straight to surgery from the get-go.
I think this is a discussion you have to have with the patients prior to starting treatment. I also treat head and neck malignancies, and I find that sometimes in patients who have very large disease burden that I decide to give induction chemotherapy, sometimes following 3 cycles of TPF, the tumor goes away completely, complete remission. And the patients will say to me, okay, can I just go home now? I mean, I emphatically tell them, no, the fact that you have complete remission does not mean you are cured. You still need either surgery or chemoradiation therapy for consolidation. So I think these are discussions that you have with them ahead of time. The neoadjuvant treatment is not the definitive treatment. It's part of the spectrum of the treatment that is planned for the patient.
Well, any questions? All right. Let me introduce to you Dr. Hossein.
Yeah.
Yes. Oh, Peter. You want to come to the microphone, Peter? Dr. Hossein, I think, faces the same on colorectal cancer.
Yeah.
So, do you use ctDNA in the MRD setting? There was some data presented in one of the clinical science symposium in ASCO, and I don't know if you've been using it.
So that's a great question because I know in the colorectal space we were surprised that this doesn't ctDNA is not any better than doctors following during surveillance. There are companies that are doing testing. I think that the data is not there for us to stop doing CAT scans. And still to this day, patients who are progressing have symptoms. So we use ctDNA more in the metastatic setting, when patients are progressing and you're trying to pick a new treatment or you're trying to get a new diagnosis and finding that targeted therapy. In early stage lung cancer, there's Signatera and there's upcoming, there will be more tests, but they haven't become part of practice.
We actually tried to open a AstraZeneca study here that required us to perform MRDs prior and after surgery and follow them periodically with MRD, blood ctDNAs. And the study was pulled and closed by AZ because of the approval of FDA of the neoadjuvant AZ study, Atezo study in the neoadjuvant setting. So MRDs in lung cancers, I think, is still very, very experimental right now.
Thank you very much to our two opponents. Let me introduce to you Dr. Peter Hossein. He's an associate professor of oncology at the Sylvester Cancer Center. He's going to review for us the advances on GI oncology, both colorectal and non-colorectal. Thank you, Peter.
Good morning, everyone. Thank you for coming out today on a Saturday to get some updates from ASCO. I guess this doesn't go up. Okay, so I'm going to be presenting both the colorectal and non-colorectal updates. I'll start with the colorectal first. So I don't have any relevant disclosures for this presentation. So these are the abstracts I'm going to spend some time covering. And since my two talks are back-to-back, you're going to have me for about half an hour to 45 minutes. And I'll try to not bore you to death and put you to sleep. So the two first abstracts were actually presented and simultaneously published in the New England Journal, which tells you about the impact. And in fact, probably many of you don't do GI cancers, but even people who are not seeing rectal cancer patients may have gotten messages from patients asking them about this wonder drug that caused remission in 100% of patients treated with rectal cancer. So that's the second one, the dostarlimab study. And then this paradigm trial I'll talk about, I think that that's potentially practice-changing, and then a couple of non-colorectal abstracts. So this study was presented by Dr. Jean T, who's a professor in Melbourne, Australia, who has been doing a lot of work in ctDNA in colorectal cancer. In fact, a lot of the data that we use now to inform practice has come out of their group. And I think it's a very impactful study, very instructive in how we're going to use ctDNA moving forward in clinical trials as well as in clinical practice. So just to give some background, this study is a prospective study that was conducted in patients with stage 2 colon cancer. And stage 2, there's a spectrum of patients in stage 2 that includes very low-risk patients. So stage 2 patients, by definition, are node negative, and they have either T3 or T4 disease. T3 means that the tumor penetrates up to the serosal lining, and T4 means that it penetrates across the serosal lining. And could actually be involving another organ like the bladder or the peritoneal lining, for example. And there's some patients who are low risk stage 2 who have a low risk of recurrence. So we consider a low risk of recurrence to be something like 12 to 15%. So that means that 85 to 88% of patients with stage 2 colon cancer, low risk, could be potentially cured by surgery only. And it's been an area of active research for a very long time to figure out if we should be offering chemotherapy to these patients, some of which may be very low risk. So this is a slide that I actually took from my lecture to the fellows on colon cancer. And this is how most GI oncologists think about stage 2 colon cancer. So the middle row is standard risk. So standard risk represents about 85% of patients with stage 2. And that is node negative, T3N0, and proficient mismatch repair. So now you have to have mismatch repair status in every stage 2 patient because that stratifies risk. And that is a test that is extremely easy to do. The pathologist usually does it reflexly. In fact, almost every institution now does MMR testing reflexly on colorectal samples. And that test takes 1 or 2 days to get back. So that is very important in decision making. And if you have a standard risk patient, T3N0, proficient MMR, or microsatellite stable, most of those patients have a low risk of recurrence, probably in the range of about 15%. And we would normally recommend observation. And the only time I would normally recommend chemo, have a discussion about chemo, is if it's a very young patient. If a patient is 85 years old, I probably wouldn't recommend any chemo. So the chemo that we would normally do would be 5-FU by itself, which could be capecitabine or infusional 5-FU. And then you start looking at groups which have more favorable risk. So if you take the same patient, but they have an MSI high tumor or deficient mismatch repair tumor, those patients actually have a less than 10% risk of recurrence. So we almost always, I would say always, recommend observation for those patients. And then the poor risk patients are the ones who have poor risk features like T4 disease, if you have less than 12 lymph nodes sampled, or if you present with obstruction, then typically we would recommend Folfox in those patients. But again, the benefit in this group is not that great. So what we're trying to figure out, and this study is addressing that, the dynamic study, is whether you can de-escalate treatment in low-risk people and potentially intensify treatment in high-risk people. And this study actually focuses more on de-escalation in high-risk patients rather than escalation in low-risk patients, and I'll explain why. So the optimal management of stage 2, as I said, is variable, and it's sort of an individualized approach. And we get a lot of consults for patients with stage 2 disease where they want to discuss, should I get chemo or not? And the guidelines, of course, consider adjuvant therapy in the high-risk groups that I explained, and we need more precise measures of risk reduction or risk prediction. And there are other things that we include. Sometimes now we do something called the immunoscore. There's actually an oncotype colon, which sometimes can help you in this decision. Those tests really have not been broken through widely to be used commonly in practice, but ctDNA has become so easy now to do. It's being tested in this space. Now, ctDNA in colon cancer, the data that we have to date is mostly observational data to tell us that if you have a resected stage 2 colon cancer patient, even stage 3, who has a positive ctDNA test, that patient has an 80% chance of having a recurrence within the next year or two. And then if you have a negative ctDNA, the risk of recurrence is very low. So that tells you about prognosis. So if you have a positive ctDNA, the prognosis is not great. You likely will have a recurrence. Negative ctDNA, good prognosis, likely no recurrence. Now, that doesn't tell you about prediction. It doesn't say if you have a positive ctDNA and you do chemo, you will have a better outcome. That is not guaranteed, and this is what the studies are trying to decipher right now. So the design of this study took all stage 2 patients, and the patients, of course, had to have a complete resection, good performance status, and a negative post-op scan. And they were randomized 2-to-1 to a ctDNA-guided management versus a standard of care approach. And the ctDNA-guided management included chemotherapy for patients with a positive ctDNA and observation for patients with a negative ctDNA. And that's actually regardless of what the clinical risk factors were. So even if you had somebody who you thought was high risk, clinically high risk, and the patient had a negative ctDNA, if they were in the experimental arm, those patients would be observed, not given any treatment. And then the standard of care was physician's choice, and again, based on risk. So patients who were high risk in the standard management group would be offered chemo. Patients who were low risk according to standard criteria, those patients would be offered observation. And the assay that was used in this study is described here to some extent. And this is not one of the commercially available assays. This is something called the Safe Sequencing System, which is an assay developed at Hopkins. But the premise is very similar to the Signatera test. So it's a little bit different from Signatera, but in practice, this it's more or less equivalent to a Signatera test. And I don't have any stake in Signatera, but there are two different types, as many of you know. There are two different platforms or paradigms in ctDNA testing. One is a tumor-informed approach, and the other one is a tumor-agnostic approach. So the tumor-informed approach is what was used here, meaning that the tumor was sequenced. These are post-op patients, so they sequence the tumor. They actually do a panel of 15 genes which are commonly mutated. So it's not a whole NGS panel that has hundreds of genes in it. This is a panel of 15 genes for this particular test. And if one of those genes was mutated in a characteristic fashion, they would probe the plasma to see if that mutation was detected. And by doing a tumor-informed assay, you can get a much deeper level of profiling in the blood. Whereas if you do a tumor-agnostic approach, the depth of sequencing is usually less. So this is more sensitive to pick up what we refer to as MRD, or minimal residual disease. And of course, this is picking up tumor-related DNA in the blood. And we believe it's tumor-related because we proved that the tumor had the same mutation. So this is not commercially available, but if we had to apply this in practice, we would probably use the Natera test. So the statistics, I think, are a little bit important here, because one of the criticisms of this study was that it was potentially underpowered. And there's another study which I'm going to mention to you that is accruing right now called a COBRA trial, which has a target accrual of 1,400 patients in stage 2 patients, whereas this study target accrual was 450. And some of the people in the US cooperative group system, in fact, I was on an ECOG meeting yesterday, and a lot of the people in the ECOG group who designed the COBRA trial in conjunction with the NRG group were very kind of upset that because they thought that this study was underpowered, and it's now going to shift people towards doing this as standard of care and not enroll patients on the clinical trial, which we believe is a more definitive approach. So this is the schema. So the ctDNA, you remember, was a 2-to-1 randomization, so approximately 300 patients in the experimental arm and 150 patients more or less in the standard arm. And the intention to treat population was 294 and 147, and there were just 5 patients in the experimental arm who declined the assigned therapy or failed ctDNA analysis. So it was really, I think, the intention to treat population is representative of what happened in the study. So both groups were well balanced in terms of risk. If you look at performance status, T-stage, nodal status, and whether you would consider them to be high risk, they were very well balanced. And this shows you the receipt of chemotherapy. So can I go back? So if you look at the last row of this table, clinical high risk was approximately 40% in both groups. And if you look at the receipt of chemotherapy, that 40% of patients, which represented about 41 patients in the standard arm, received chemotherapy, and most of them received fluoropyrimidine like Xeloda by itself. And then in the ctDNA guided group, patients who had high risk, patients who had positive ctDNA were the ones who got chemo. Most of them received oxaliplatinum-based chemo like FOLFOX. Now, this shows you really the crux of the study, which is a de-escalation that occurred in these patients. So if you focus on the first red bar, and I'm going to try to get closer to this screen because I can't see it very well. So if you focus on the first one, which is clinical high risk, the green bar, so in this bar graph, the green one, or I guess that's a turquoise color, is showing you that there were a significant amount of patients with clinical high risk in the standard management group, and who received chemotherapy. And in the ctDNA group, which is the orange color, those patients had less receipt of chemotherapy. So basically, chemotherapy was given in about half of the patients with clinical high risk in the ctDNA group. And what does that mean? Well, the high risk patients, about half of them had negative ctDNA, and those patients did not receive any adjuvant chemotherapy. And you will see in the next slide that actually that did not affect recurrence. So this is a recurrence-free survival showing you the two arms of the study, and they basically overlap. So in the ctDNA-guided group versus the standard management group, there was overlap, and what you ended up happening was that you had much less chemotherapy given on the ctDNA group versus the standard management group. So this is and this was designed as a non-inferiority study, and it met the criteria to be non-inferior, and that is what they were trying to achieve. So the point of this study wasn't to show superiority of a ctDNA-guided management, but it was to show that you can exclude chemotherapy from some patients that you would normally give chemotherapy to, and it was not detrimental. So, similar in paradigm to the TIL-Rx, for example, where you wanted to de-escalate from relatively low-risk adjuvant breast. So this is sort of a similar concept, of course, using a different platform. And in key subgroups, the same finding held up. In patients who had T4 tumors, they had, some of them were ctDNA negative, and they didn't receive chemotherapy, and there was no detriment in recurrence. Now, this is an important figure. So this shows you the overall, this is pooled between two arms now, ctDNA negative versus positive. And there's a difference, of course, with the ctDNA positive patients in terms of recurrence. And what you have to remember is that red line that you see there for ctDNA positive, without intervention, you remember there were previous studies that looked at ctDNA positive patients by the same group, and they showed an 80% risk of recurrence. And in this study, they're showing at about 4 years a 14% risk of recurrence. So this is actually showing you that the ctDNA not only is prognostic, but it can be predictive, or can help you determine management. So the red line would normally plummet in the first few months after surgery, right? So if you have a positive ctDNA, you'd expect that red line to go down. Like, let me see. This red line here should drop like this. So the red line actually moved up. There's no control group here to show that ctDNA positive without treatment what happened, but we have that from historical data. So these patients actually did better than expected despite being ctDNA positive. And the study team said that they were going to present kinetics of response to see when those patients turn from positive to negative, and duration of chemotherapy. Those are still open questions. But this I think is a very important finding in this study, that you can rescue patients who are almost destined to recur by giving the adjuvant treatment. And this is something that we didn't know, or what we hadn't proved before this study. So the summary of this clinical trial is that for patients with stage 2 colon cancer, ctDNA approach, treating only positive ctDNA patients with chemotherapy, substantially reduced the proportion of patients receiving adjuvant chemo from 28% to 15%, and it did not compromise the recurrence-free survival. You can see that the recurrence-free survival here was almost identical, 93.5 versus 92.4%. And a patient with positive ctDNA after surgery may derive benefit from adjuvant chemotherapy. And you can avoid chemotherapy in patients who are ctDNA negative with low risk of recurrence. Now, the other study that I mentioned to you, which is ongoing in the US right now, is this NRG study called a COBRA trial. And this is asking a slightly different question. So this is looking at patients who have only stage 2A disease, so no T4, no high risk, only T3 and 0. And looking at standard of care, which is actually the criteria for this study is that patients would be recommended active surveillance only. So if I see a patient and I thought that patient was a candidate for chemo, the patient would not be a candidate for this study. It has to be a patient with stage 2 that I think is relatively low risk that I would normally observe, and we can put them in this study to see if that low risk, clinical low risk group, if we can find some of those patients that are ctDNA positive and whether those ctDNA positive patients would benefit from chemotherapy. Now, it's likely, based on the dynamic trial that I just showed you, that those ctDNA positive patients would benefit from chemotherapy. But the question is how much benefit they would get, because if you have a T3N0 patient, you would expect the benefit from chemotherapy to be very small. So this study is designed to answer that question. I think it's a different question because this is looking at intensifying chemo or giving chemo to patients that you would have avoided chemo before. And the dynamic study was really trying to de-escalate chemo in patients that you thought would be candidates for chemo. So this is still an important study. But one problem is when you have data like this and the field is moving so quickly that many patients are educated and they go online and they see advertisements for these tests, and they ask oncologists about it. And many oncologists are using it now in practice. These tests are commercially available. So if I have a patient now in my practice with stage 2 disease, I routinely check a ctDNA, and my partners who do colorectal do the same. All of them check ctDNA in the post-op setting. And then you have to make decisions based on the data that you have in front of you right now. And based on the data we have right now, you know that if it's ctDNA negative, you probably would not recommend, I would say you should not recommend chemotherapy, but if it's positive, we have data from that previous study that chemotherapy may be beneficial. So you kind of lost a little bit of equipoise in randomizing patients in a study like this. But we still believe that this will answer a separate question, but it's a very high target accrual, and I'm not sure where they are in this study yet because it was closed for a little while. But I'm hoping that we can get this study completed. So that's one of the most impactful studies that was presented this year in ASCO. I'm going to move on to the second one, which is the one that made a lot of waves on CNN and New York Times. The PI or the presenter of this study was interviewed on CNN the day after the presentation. So this is looking at PD-1 blockade as curative intent therapy in mismatch repair deficient locally advanced rectal cancer. And I'm going to poke a little bit Dr. Ikpeazu, who said that in head and neck cancer, if you give neoadjuvant immunotherapy or chemoimmunotherapy, that is a means towards a definitive treatment, which is surgery. But this study actually was looking at PD-1 blockade as destination treatment, not as a bridge to something else. And there was still a backup to do radiation or do surgery in case the patients didn't respond, but it turned out that every single patient had a CR in this study. So therapy for locally advanced rectal cancer, as many of you know, is normally trimodality. We usually give chemotherapy, radiation therapy, and surgery. Locally advanced is defined as T2 or T3 and node positive. And now the standard of care has moved towards what we refer to as total neoadjuvant therapy, which includes chemotherapy usually for about 4 months, and then chemoradiation usually for about 5 or 6 weeks. Sometimes we do short course radiation for 5 days, and then we do surgery. And many groups have tried to de-intensify that treatment for patients who have had a complete clinical response to total neoadjuvant therapy. Is there a role to avoid having surgery? Because, rectal surgery, some patients end up with a permanent colostomy, and there's some functional issues that impair quality of life. So if you can cure patients without surgery, that's one of the things that we are investigating. In fact, we just activated an investigation-initiated study at to investigate this. So we know that immunotherapy has a high response rate in patients with MSI-high colon cancer. And the premise of this study is whether that high response rate could translate into clinical complete responses and possibly cures in the upfront setting and may avoid patients from getting chemotherapy and radiation therapy. Now, this represents a relatively small proportion of patients, right? It's only about 5 to 10% of rectal cancer patients. But, the presenter was making the point that the incidence of this disease internationally is 750,000. And that overall in the world, you probably be talking about 50,000 patients. And there are some countries where radiation is not easily accessible, or surgery, the expertise to do a total mesorectal excision doesn't exist. And, of course, you have to balance that against the cost of immunotherapy if you want to say that this could replace 3 modalities of treatment. But, it's something that is potentially impactful, because we clearly see patients like this. And we also know that in addition to having a high response rate to immunotherapy, these patients have a low response rate to chemotherapy. So this is the reason to do this study. So the hypothesis is that whether the PD-1 inhibitors can replace chemotherapy or replace chemo and radiation therapy, or replace all 3 of them. So this is the schema of the study. So patients had to have, of course, mismatch repair testing at the time of diagnosis. And they had a detailed examination. And again, one point that the discussant made on this study is that there are not many centers that have all the multidisciplinary expertise to execute a program like this, because you have to have very strong multidisciplinary input to do something like this, and you have to be able to do all the proper staging in a timely fashion. So first of all, you do a biopsy, you do an MRI of the abdomen, of the pelvis, and the gold standard now is MRI staging for rectal cancer, and then you need staging for the rest of the body. And you need endoscopic evaluation as well, because I'm going to show you some pictures from patients in this study to prove that they actually had a complete response, because it's not just based on MRI, but it's based on endoscopy evaluation, right? So to do all that, you need a very strong team. And I am proud to say that UM recently got accredited in their rectal cancer program as a center of excellence, because we have a very strong multidisciplinary team doing this. So we could potentially replicate something like this in our center. So what they did was that patients were treated as a single-arm study, 2-stage design. First stage was 14 patients, the second stage is 16 patients. And the data presented here was on the first 18 patients, where the first 14 were evaluable. And patients were treated with 6 months of dostarlimab, which is a PD-1 inhibitor. And if they had a clinical complete response, they were followed with surveillance. If they had any residual disease, they would go on to chemoradiation and possibly surgery if they still had residual disease after chemoradiation. So more or less, there's an algorithm that has a standard of care component to it. But you have the opportunity to get off the standard of care algorithm if you achieved a complete response. So the primary objective was overall response rate, and that's how they set up the 2-stage design, and you had to have a threshold for response to get to the second stage, which they clearly exceeded. And that's why they presented the study when they exceeded the first the first interim analysis. So, this is a typical patient population. Importantly, all the patients were wild type for BRAF V600E. If you have a right-sided colon cancer, which is MSI high, maybe up to half of those patients have BRAF V600E mutations, but these patients were wild type. And the median TMB is very high, 67 on the study. All of them were MSI high, obviously, and that goes along with a high TMB. And all of them were locally advanced. So this is one case that really illustrates very well what happened to these patients. So this is a very ugly-looking tumor endoscopically. And after 6 weeks, the tumor is almost gone. After 3 months, there's absolutely nothing that you can see that this is normal mucosa, and it remains normal all the way through. And then on MRI scan, the tumor is right here. On the PET scan, you can see it there on the anterior wall of the rectum. And then with time, that regresses. The PET uptake disappeared by 3 months. And this is one illustrative case, but this is what they saw in all the patients. So the 14 patients that were enrolled in the study, very wide range of age, stage. It looks like they copied and pasted the last few columns of this thing. But they achieved complete response in 100% of patients. And this was the first 14 evaluable patients. And they had 4 additional patients enrolled by the time of this presentation. And 1 of those 4 also achieved a complete response. The other 3 were still pending evaluation. So really, they presented 15 CRs out of 15 evaluable patients. And this is the duration of response. So one of the criticisms of this study is that there was relatively short follow-up. The median duration of follow-up was 6.8 months, but the first patient has already been followed up almost 2 years and still in complete remission. So 100% clinical complete remission in the first 14 patients, no grade 3 or 4 adverse events, and no patients required chemotherapy, radiation, or surgery. And of course, the presenter said that they needed longer follow-up. And now they introduced a new term, which I had never heard before. This data provides framework for immunoablative therapies, I guess in MSI-high tumors. And we've seen patients, of course, with MSI-high tumors achieve CRs. But I haven't thought about it as immunoablative until now. This has the potential to lead to a change in the standard of care. Now, the next couple slides are taken from the person who discussed the abstract and agree, and I think I agree with these conclusions, that the results are clinically meaningful. Are they scientifically plausible? Yes. Practice changing? Not yet. And the reasons are that you had a small sample size, short follow-up, single institution. I mean, this is the mecca, right, of rectal cancer, Memorial Sloan Kettering. They have some of the biggest names in the world. Len Saltz, some of the radiation doctors there are people who lead the standard of care in this disease. And also response rate was a primary endpoint. We don't have full survival data yet. So the problem here is that a randomized study is probably not feasible, because I think based on this study, we probably already lost equipoise. And, a lot of people probably will be using now off-label neoadjuvant immunotherapy. However, there's a cooperative group study ongoing right now through ECOG. Actually, a friend of UM is the PI of that study. It's somebody who trained here, Kristen Siambo at Vanderbilt right now. She is running a neoadjuvant Ipi-Nivo study followed by SBRT and possible non-operative management for these patients. And that study is accruing right now. Now, we discussed whether we should change the design of that study and omit radiation based on these results, but we decided to leave the study intact because, there still may be some patients who would benefit if they still have residual disease from radiation. And there's some, of course, synergy between radiation therapy and immunotherapy. So what I foresee here, and this is not something that is unrealistic, we know that the initial tumor-agnostic approval for pembrolizumab in MSI-high tumors was based on a small study with a high response rate as a primary endpoint. That was the initial study by the Hopkins team that led to the tumor-agnostic approval of pembrolizumab. And I think that since we have precedent for that, it's possible that when this study finishes accruing, and if we have data from the ECOG study, it's possible that we may get an approval without a randomized study. I think that that's likely to happen, maybe within the next year or two. So again, what is needed? Larger sample size, longer follow-up, and multi-institutional participation. And I think we will achieve that within the next at least 1 or 2 years. And then there's some questions. I'm going to skip over this to get to the other abstracts. So this is the last colorectal one, and I'm not going to spend as much time on this. This one actually was in the plenary session, but didn't have a concurrent New England Journal publication. This is a study of an anti-EGFR antibody with Folfox versus bevacizumab with Folfox in RAS wild-type metastatic colon cancer. And you might say, well, is this really an important question? Do we know the answer to this question already? And I'll show you why this was an important study. And probably the first time we are seeing specific data in this setting. So we know in colon cancer that RAS is the first biomarker that was shown to be predictive, prognostic and predictive. So it's a negative selection factor. You have to have RAS wild type to benefit from an EGFR monoclonal antibody. And I don't know how many of, definitely Wasim wasn't around in 2004 practicing, but this was when I was a fellow. When cetuximab was first approved, it was actually approved based on positive EGFR expression in the tumor, which nobody checks anymore. I don't think I ever seen a report reporting EGFR expression in a colon tumor. And, we found from actually analysis, very, very elegant analysis in many of the European studies looking at EGFR monoclonal antibodies, that there was 0 responses in patients who were RAS mutated, and all the responses were in patients who were RAS wild type. So that's when the label changed in 2008 to include patients only with RAS exon 2 wild type, and that cut out about 60% of patients. 40% of patients were cut out from EGFR monoclonals. And then when we moved from only KRAS to all RAS, then we cut out a little more patients. So now about 50% of patients will be eligible for EGFR monoclonal antibody therapy. And in the RAS wild-type patients, now we always get these tests up front, right? So in order to decide what to do for a metastatic colon cancer patient, we need MMR status, we need RAS status, BRAF status, and possibly HER2 as well. So we have a panel that we normally do when somebody's first diagnosed, and we can usually wait to get those results before we decide on treatment. So the question has been going on for some time, if you have a RAS wild-type patient, because the standard of care before this was chemotherapy plus bevacizumab. So should we do chemo plus bev, or chemo plus cetuximab, or chemo plus panitumumab? And we know that the triple combo of chemo, bev, and an EGFR monoclonal is frowned upon because that showed actually worse outcomes when you do that double antibody combination. So we don't try to combine those antibodies, so we're trying to figure out in these patients whether they should be treated up front with a EGFR monoclonal or bevacizumab. So there have been 3 studies already. And the problem with these studies is that they looked at all patients, all colon cancer patients who are RAS wild type. And we now know that there's a difference between right-sided RAS wild type versus left-sided RAS wild type. And this is the reason why this current study was done. And I'll show you what happened to these studies. All of them were sort of washed. They showed equivalence in all of these, but they showed benefit in the subgroup of patients with left-sided wild-type tumors. But the studies were not powered enough to look at that, to really conclude that they were beneficial in that setting. So this was the sub-analysis, or the pooled analysis, I should say, of those 3 studies, FIRE3, CALGB, and the PEAK study. And all of them show that the hazard ratio for left-sided RAS wild-type with the EGFR monoclonal antibody was better for both overall survival, response rate, and progression-free survival. But the numbers were really too small, and this was sort of a post hoc analysis that wasn't definitive to decide whether it really is beneficial in that subgroup of patients. It was suggested, but it wasn't definitive. So in those 3 clinical trials, there were almost 3,000 patients. And when you take out the RAS mutant patients, you come down to about 1,000 patients. And the right-sided represented about almost 1/3 of them, and the left-sided ones, almost 2/3 or 73%. And this is a subgroup that we believe drives the benefit to the EGFR monoclonal antibody. And that really is what this study was trying to test prospectively. So it was a straight randomization, 1-to-1, FOLFOX panitumumab versus FOLFOX bevacizumab. And the study changed the endpoints with time. They actually decided that overall survival in the left-sided subgroup would be the primary endpoint for the study. And if that met the primary endpoint, then they would analyze overall survival in the entire study population. And the study was positive. Now, we've seen this kind of overlap in curves in other studies, especially in chemoimmunotherapy studies, where you have the experimental panitumumab plus FOLFOX initially a little bit below in the overall survival, and then eventually is the winner. And the hazard ratio was 18% improvement in survival. And this was considered to be a positive study in the left-sided population. This met the threshold for being positive. So really, for the first time in a prospective fashion, we showed superiority of an EGFR monoclonal with chemo over bevacizumab. And I think this is something that now has the potential to change the standard of care, especially in patients where you want to have a response to resect them. So many patients with metastatic colon cancer are candidates for curative resection of liver metastasis, for example. So if you have 1 or 2 liver mets, Normally, we start with some type of chemotherapy, and the response rate, sorry, let me go back here. The response rate, and also, so the disease control rate was very high across the board. The response rate was probably the highest in this group in left-sided patients. 80% response rate, objective response rate, was a very high response rate. And then the R0 resection rate of 18% is substantial. These are patients who had complete resection of metastatic disease. So if you're trying to do some kind of conversion treatment, then this is a superior option for those patients. So I'm going to jump to the algorithm now that was proposed by the person who discussed this study. And this is now what we do up front for RAS wild-type patients. We check MMR status. And this is, I didn't show any data on this, but this has been established in previous trials that patients who are deficient mismatch repair MSI high should get single-agent immune checkpoint inhibitor or even dual checkpoint inhibitor up front. And if you're MS microsatellite stable, BRAF mutated, then you can do FOLFOX-Bev or FOLFOXIRI-Bev. And if you have a wild-type, RAS wild-type and BRAF wild-type, then you decide based on the tumor-sidedness what you do. So a chemotherapy doublet plus EGFR antibody in left-sided tumors, and then you can intensify with FOLFOXIRI-Bev or doublet plus Bev in right-sided tumors. So this is the algorithm now that has been established based on this clinical trial. So that's the end of the colorectal session, and I think I'm out of time completely. No, I still have a few minutes. The last two abstracts are relatively quick. So I'm going to do the non-colorectal session quickly. If you want somebody else to present, we can call somebody else up. So this study, I highlighted this study because this is, I think it was a practice-changing study by our ECOG group. You know, we are affiliated with this group, and we actually had this study open at UM and contributed some patients to it. So the CAPTEM study is a study of capecitabine temozolomide versus temozolomide in patients with advanced pancreatic neuroendocrine tumors. And this is not the first time this study has been presented, but this is sort of a final analysis of the efficacy, as well as some biomarker analysis that was presented by Dr. Coons. So the primary endpoint of median PFS was met for this study with a hazard ratio of 0.58, so 42% improvement in progression-free survival with CAPTEM versus TEM only, versus temozolomide only. And this has really cemented itself as part of the standard of care treatment for advanced pancreatic neuroendocrine tumors. So I'm not sure if I have an algorithm in my slides, but essentially what we do in pancreatic neuroendocrine tumors, if you have a grade 1 tumor, which is with a low proliferative index of Ki-67 less than 3%, we usually start with a somatostatin analog. But most of the pancreatic neuroendocrine tumors have intermediate grade proliferation, so that would be a Ki-67 anywhere from 3 to 20%. And even grade 3 in the above 20% range, many of these patients, in fact, most of these patients benefit from CAPTEM as well. So in those patients, many times we use CAPTEM up front based on this clinical trial. And previously we had single institution retrospective as well as some uncontrolled prospective studies with CAPTEM, and this was the first randomized study showing efficacy of CAPTEM for these patients. And it has a relatively high response rate. And one of the questions that they were trying to answer here is whether MGMT is a biomarker that we should routinely be using to select patients for CAPTEM. And the short answer is no. And we know that MGMT status is tested in brain tumors for temozolomide, for prognostication as well as for temozolomide use. And the theory, of course, is if MGMT is low, then you would likely to have a better response to temozolomide. And that wasn't clearly shown in this study, but it wasn't really powered to do that. So I talked about most of this already, that CAPTEM is superior to TEM in advanced pancreatic neuroendocrine tumors. And these are some of the other options available. nobody uses streptozotocin 5-FU anymore. CAPTEM has really supplanted that regimen, and we also have options of using everolimus, sunitinib, surufatinib, and lanreotide, but CAPTEM really is a first-line option. And that is included in the guidelines. So this discussion was presented by Dr. Pavel, who writes the ESMO guidelines. And grade 1, as I said, we usually start with somatostatin analog, and then we use chemotherapy or other targeted agents later down the line, and we have the option of PRRT as well. In grade 2, generally speaking, we do CAPTEM up front, and then we have PRRT as a backup, and then in net grade 3, we also have CAPTEM that we incorporate, especially if the tumor is sort of in a lower end of the grade 3 spectrum. If it's in a higher end of the grade 3 spectrum, then we generally use platinum-based chemotherapy. And if they're somatostatin receptor negative, then we don't have the option of doing somatostatin receptor targeted treatments. And the question of MGMT status, in general, there was a higher response rate in low MGMT patients, but it wasn't consistent, and I think it was just because of small numbers. So what was found in this study is that there were some responders who had non-methylated MGMT, and then there were some non-responders who had low MGMT. So it was not a very clean predictive biomarker. So, based on this, we cannot routinely recommend MGMT testing. Okay, so the last one, I can't do a talk without talking something about pancreas cancer. So this will be the last one, and this is fairly quick. So this is a study, a phase 3 study in locally advanced pancreas cancer. So we know that there in the clinic, functionally, there are a few categories of pancreas cancer. Of course, metastatic is a different stage and treated differently. In the localized group of patients, we have resectable, borderline resectable, or locally advanced unresectable. So locally advanced unresectable is really the main group where we generally tend to apply radiation therapy. However, they're really, up to now, is not, we don't have very convincing level 1 data that radiation therapy is effective. And the previous studies that have been done, especially European studies like the LAPO-7 study, did not show benefit of adding radiation therapy to chemotherapy. However, the chemotherapy that we used in those studies were not state-of-the-art multi-agent chemotherapy that we do now. So this is one of the first LAPC studies prospectively to test FOLFIRINOX. And in fact, some patients, it was investigated choice whether you would use FOLFIRINOX as the induction regimen or Gemza, but most of the patients ended up getting FOLFIRINOX. So 4 months of FOLFIRINOX, and then if they didn't have progression, they would be randomized to chemoradiation with Gemza, followed by some more Gemza. And the control arm is just to continue whatever chemotherapy they were on before. Now, they had problems with accrual. The accrual was relatively slow, so they changed the endpoint from overall survival to R0 resection rate, the primary endpoint, and overall survival became a secondary endpoint, but the study unfortunately wasn't powered to look at overall survival. So there was actually no difference in progression-free or overall survival in this. Again, similar to the LAPO-7 study, but what was the main finding of this study was that there were a much higher proportion of patients who were able to make it to surgery, especially in the patients who had FOLFIRINOX followed by chemoradiation therapy. And this is that curve. Now, a lot of surgeons will present these data and tell you that the only way you can be cured from pancreatic cancer is with surgery based on this, but you cannot really conclude that from this because this is not a randomized comparison of surgery versus no surgery. This is just patients who made it to surgery regardless of which arm they were assigned to. So really making it to surgery is sort of a prognostic indicator that your tumor was sensitive to chemotherapy, that you responded from an unresectable situation into a resectable situation. And the patients who were in the lower curve here were patients who had unfavorable biology, unresponsive to chemotherapy, didn't make it to surgery, and not making it to surgery is the same as saying they didn't have good biology. So really, you can't say here that surgery helped them to survive longer. Maybe, but one thing you can say is that if you respond to chemotherapy and you make it to surgery, you have a chance of having some 5-year survival. So there was some 5-year survivors in this study. And I think what we can conclude from this study is that if patients are fit enough for FOLFIRINOX and chemoradiation, some of those patients may have good long-term outcomes. And that's kind of backing up what we have been doing up to now. So this is my last slide, and I hope I did not put you to sleep. I will stop there, and I will be very happy to answer any questions. Thank you.
I have a couple of questions. Now, in the pancreas study, would you therefore conclude that it is probably best to take those patients who responded to chemo to surgery? Because I don't treat pancreas, but it's kind of unfair that, the other group that did not fully respond with CR went to chemoradiation and then went to surgery and had a better overall survival. So I would think that those patients who responded in this particular, at least from judging from this study, should also go to surgery.
Patients who did not respond?
No, patients who responded.
Are responding, yes.
There were two groups. Exactly. From this study, it seemed to me that everybody should end up going to surgery.
So that's what the study included patients, or allowed patients to go to surgery if they were deemed to be converted to resectability, regardless of which arm of the study they were in. So if they were in the chemo control arm or in the chemo followed by chemoradiation arm, if their tumor converted into a point of resectability, they would take them to surgery. Is that...
So now, based on the response, the curves that we saw, so what do you do with these patients? Because it's clear that the surgical patients did better in terms of overall survival.
Right. Yes. Okay. However, you can't say it was because of the surgery. It may be because of the surgery, but you cannot say that definitively based on this study.
I see.
So what you're saying is that the patients who made it to surgery are the patients who were fit, patients who had a good response, whose tumors were more susceptible to chemotherapy. And, basically surgery was like a treatment that they had the benefit of making it to, whereas the other patients, if they didn't respond, then they were not able to make it to surgery. So really it's telling you about the sensitivity of the disease to the treatment, not really about the effect of the surgery.
I see.
All right. And we cannot do a randomization for patients who are potentially resectable to surgery versus no surgery. Okay. But what you can say is the patients who went through all three modalities did better than patients who didn't. But not every patient can get through all three modalities. So that's sort of a prognostic thing. And there were other studies. So, the group at Memorial Sloan Kettering presented data recently on SPRT, or ablative radiation therapy. And what they showed is that the only patients who benefited from ablative radiation were the patients who had a good response to the induction regimen, the chemo regimen. So if you didn't respond to the induction regimen, you would not benefit from radiation. That's what they showed there. So really it's a biology issue that you select out the best patients, and those patients are likely to benefit from radiation and more likely to make it to surgery.
Surgery, okay. Now the other question I have has to do with your ctDNA. In lung cancer, we try to start adjuvant treatment within 4 to 8 weeks. Some people extend to 12 weeks post-op. Now, so when post-operatively, when these patients have negative ctDNA, you observe them, at least according to the study. Mm-hmm. Now, how frequent do you check ctDNA?
So that's not well defined. In the commercially available assay that I alluded to in my talk, the tumor-informed assay, you can check that every 3 months. Mm-hmm. So in the requisition, there's an option to check it one time or to check it every 3 months. And essentially what the company will do is send a phlebotomist home to the patient's house once every 3 months to collect a blood sample. And I get those results automatically. I don't have to reorder them every 3 months. Sure. So, and people are looking now at the kinetics of correlating the initial stage where they start off being negative and then they turn positive or they stay negative. And it's still an area where we are learning a lot about.
Yeah.
But I think part of the question that you're asking is whether you can turn around the test quickly enough to make an adjuvant decision. Is that what you're asking?
Yeah, I guess, I'm wondering, what happens if 6 months from now, the ctDNA is positive?
So we have that dilemma in the tumor board very frequently.
Yeah.
So we have some patients who have no evidence of disease and their ctDNA turns positive and you can't find anything on the scan.
Sure.
So in those patients, what we do is that we just keep following them until we find something.
Yeah.
So if the ctDNA usually precedes radiographic evidence of recurrence,
correct, yes.
and if 2 months later or 3 months later you find something that's potentially resectable or ablatable, then we would do that. But of course, if you find something that is unresectable or doesn't make sense to take out, then we would start treatment. But so far, we have not started treatment on people
based on
who
ctDNA.
have a ctDNA that was negative, that turned positive, if you don't have radiographic evidence of disease on scan.
Yeah, it's kind of interesting. I had a colorectal colleague who had a positive ctDNA on the patient several months post-op, and he based on ctDNA negative scans, he started the patient on treatment, and I think according to this guy, 2 years post that, he's still negative radiographically. I just want to throw that in.
So sort of delayed adjuvant therapy, is that what was done?
Exactly.
Interesting.
And let me expand a little bit on that, Peter. I mean, I'm not a colorectal oncologist, so on the guidelines, as far as I remember, CEA is one of the few markers that are still recommended to be followed on patients on observation. Am I right?
So I don't think it's
amongst other tumors, just for colorectal cancer.
For prognosis, yes, but as of now, up until the dynamic study was presented, and this dynamic study has not been incorporated into the guidelines yet. So yes, it is recommended as a prognostic marker, but not to inform decision making up to now.
Now, so is this becoming on the community and on general practice? Is this becoming a standard practice, even though it's not on the guidelines?
Yeah, we see, in our practice, it is routine, and we see patients who come for opinions, and most of them have ctDNA results with them.
Okay.
I have a question how to deal with the anxiety of positive ctDNA. I'm starting to deal with that in our breast cancer patients where we, as I'll present later, know that SBRT-directed therapy of metastases does not improve prognosis. So I have not routinely been doing ctDNA. But how do you deal with a patient with positive ctDNA after therapy? I mean, you can use it to decide on chemotherapy as an adjuvant, but then you keep following it, I assume.
Yeah.
And how do you deal with those patients and they're living their day-to-day lives?
So it's challenging. So
Almost better not to check.
So that's one of the arguments when we were discussing the COBRA trial, which is the one to try to intensify treatment in low-risk patients. One of the issues is that, some people who turn positive and you can't find anything, patients from a psychological perspective would be very distressed. And how we deal with that is that how I approach it is I tell the patients, it's likely that we're picking up something very early and we potentially have a chance of affecting the disease course if we can find what it is that is driving this and try to eliminate it. So that's the reason why we do surveillance scans on patients with colon cancer, because we know that you can potentially cure some patients with metastatic recurrences. And we've known that for a long time. So it's another tool that we have for sort of early detection of recurrence. And, the theory really is, and in breast cancer, I don't think that's been proven yet, but the theory is that if you can intercept something earlier, you're more likely to have a curative outcome. But it becomes a difficult discussion, right? So if you know that the patient has a recurrence, does it make a difference to start chemo 2 or 3 months earlier? Does it make a difference to know 2 or 3 months earlier? Because that patient would have probably had a good quality of life, may have taken a trip or something like that during that time, not thinking about cancer. but now you throw everything into a tailspin if you have that test. So it's challenging. It's something that we haven't completely solved.
My other question is about the rectal cancer trial. I mean, obviously that's a very small subgroup of patients, but if you didn't have a trial and a patient, a 30-year-old, premenopausal woman who wants to have children walks in your door with MSI high rectal cancer, are you going to treat her off study with this?
It's an option, I think, but the study actually had sort of a get out of jail free card, which is the backup option of doing standard of care chemoradiation followed by surgery if you didn't have a response to immunotherapy. So if you're going to commit to doing that off-label, then you have to have a plan to follow up very closely with imaging, with endoscopies, and pull the plug on that approach if you don't see an early response. But fortunately, most patients will have a good early response. So the other thing is that we try to direct those patients into the ongoing ECOG study, which is ipi-nivo and radiation. But it now with the data that we have, it's definitely part of the discussion because we can get the PD-1 inhibitors even reimbursed by insurance in this situation. It's technically off-label, but we can usually get it. I know a lot of people would ask for that, yes.
I missed the beginning of your talk, and was ctDNA obtained prior to surgery?
No. So it's a tumor-informed assay, so you have to have a tumor to develop the assay specific for that patient. So it's similar to the Natera test. So
Yes.
Yeah, so for rectal study, so for the pembrolizumab study, 50% of those patients across the tumor board responded. So what was different in this rectal study patients? Is rectal cancer, is PD-1 inhibitor, or what is your thought on that?
So the theory there was that earlier stage, for example, the Pembro frontline study had a significant number of patients who had liver metastasis. And there's some data to suggest that liver metastasis can it's an immune desert, so to speak. And that can reduce the responsiveness to the immune checkpoint inhibitors. So if you have only primary disease and even nodal disease, it seems like those patients have a better chance of response to immunotherapy. So that really is the theory. And also, it seems like left-sided or rectal, the further down the GI tract you go, you have a lower chance of having BRAF mutations along with the MSI high. So that may be driving the response, the responsiveness to that we saw the higher response rate in this population compared to the frontline Pembro study in metastatic patients.
So do you really need ipi-nivo?
Sorry?
Do you really need ipi-nivo for those patients if you're having people in our study with ipi-nivo?
So
It's definitely less toxic than ipi-nivo.
yes, that's a great question. So when we designed the ECOG study, of course, nobody knew about the results of this study, right? So we thought that based on the data in the metastatic space where ipi-nivo had a higher response rate than the single agent PD-1 inhibitor, when you're doing neoadjuvant therapy, response rate is important. So that's why ipi-nivo was chosen at that time. We didn't have that much data in this space for a single agent PD-1 inhibitor, but extrapolating from the metastatic space, because it had a higher response rate, that is why ipi-nivo was chosen. So, it's a small study, so it's not like if we're exposing 1 million patients to harm, right? It's being done in a controlled setting, and most of the centers are academic centers that can deal with complications.
You have 55% of grade 3 immune-related adverse events. It's pretty toxic regimen. We use it a lot in kidney
Right.
cancer. It's the least favorite regimen in my practice. So,
Well,
with this data, we think twice with the alpha patient people.
yeah. So fortunately, that study is close to finishing accrual. So we'll find out.
I have a few questions. I don't know how pertinent that could be or applicable from the online audience. So one of them, jumping to the non-colorectal cancers. I think that you answered it when you gave the algorithm for treatment for neuroendocrine carcinoma. But the question is CAPTEM better than Lutathera?
So that's an outstanding question. So that is a difficult question to answer. We don't have the data to answer that question right now, and there is a randomized study being planned through the cooperative group of CAPTEM versus Lutathera for these patients. Now, based on the data that we have right now, there's some issues to consider. One is that Lutathera, which is lutetium-177 dotatate, it's a radioisotope that has some risk of bone marrow toxicity. There's about a 2% risk of long-term myelodysplasia with that regimen, with that infusion. And what has been seen anecdotally in some series is the sequence of PRRT with Lutathera followed by CAPTEM leads to a higher rate of bone marrow problems, whereas the reverse order does not. So if you do CAPTEM first and then you do Lutathera second, you don't see as much bone marrow failure. I've had some patients who develop neutropenic fever with Lutathera followed by CAPTEM. Not in close succession, but patients who had a prior history of receiving Lutathera and then receive CAPTEM later down the line. So that's one consideration. The second consideration is that Lutathera is a somatostatin receptor targeted treatment. And somatostatin receptor expression is highest in very well differentiated neuroendocrine tumors. So the lower grade tumors have higher density of the receptor expression. And as you move up the spectrum, as you go from grade 1 to grade 2 to grade 3, the somatostatin receptor expression decreases and you have more higher grade disease that does not express somatostatin receptor. So the higher grade patients are more likely to respond to a chemotherapy approach than the lower grade patients. And I'm not talking about grade 3 versus grade 1. Even within grade 2 or low grade 3, you don't have as much somatostatin receptor expression in some tumors. And now, what we are doing, actually based on some very nice work from the same Australian group that did the ctDNA study, where they did dual PET scans. So they did a somatostatin receptor PET scan, which is called a PET dotatate scan. And then on the same patient, you do an FDG PET scan. And you can define in the same patient which areas of disease is low grade and which areas of disease is high grade. And we have now, in my practice, probably about 10 patients where we have both PET scans done in close succession. And you can see, if you put both PET scans up next to each other, and you look at the liver, for example, there's some tumors that are very bright on somatostatin and cold on FDG, and vice versa. So the decision is very nuanced, whether you would go with a somatostatin receptor targeting versus a chemo targeting. And what my approach is to try to define these tumors. These patients always have heterogeneous disease, right? There's not, if you biopsy different areas, you'll find different Ki67 labeling. And what I try to do is to define if there isn't any high-grade component, usually treat that with chemo first, and then clean up what is left with the Lutathera treatment at the back end. And that's an approach that a lot of people are using. And I think from an oncologic standpoint, it makes sense to try to treat the higher grade component of the disease first. And then you wouldn't expect the low grade component to progress significantly during the time that you're giving chemo. And the chemo will also have some minimal activity against the low grade component. But then the somatostatin receptor treatment will target the low grade component. So that's how I think about balancing those two options.
Let me take this as the last question from the online audience as well. How do you treat, or what do you offer for first-line treatment for patients who are PD-L1 positive and at the same time KRAS G12C mutation positive? Chemotherapy, immunotherapy? I mean, this is the way the question comes.
That's probably a lung cancer question.
Yeah, I mean, I figured that was it. I mean, yes, if a patient presents with PD-L1 positive tumor and at the same time a KRAS J12C mutation positive, what would you offer as first-line treatment?
So chemoimmunotherapy is still the first option because those patients with the best KRAS today
doesn't need chemo. Now we know that most of those patients will progress, and then you have a second.
Okay.
So just for the people in the online audience who may not have heard the answer was immunotherapy first, and then the chemoimmunotherapy first, and then the as a second line or later line option. Right.
Would you use that as a follow-up of that? I mean, after a set number of treatments with chemoimmunotherapy? Before progression, yes.
There's no data, I mean, like a maintenance strategy?
Yes.
No.
Okay.
Probably in clinical trial.
So the answer would be to wait for progression.
Right, and also what we know about the G12C inhibitors is that there's relatively quick induction of resistance. So it's not something like a KIT, like imatinib in a KIT mutated GIST that will keep the disease under control for years. That doesn't happen with these G12C inhibitors. You can think about it like the BRAF-MEK combo for BRAF mutant lung or any other tumor, where you will get some mileage out of it, but it's usually not extremely long. They usually have resistance mechanisms, and there are a number of approaches now looking at combination therapies for targeting KRAS for G12C and for the variants of KRAS.
Thank you very much. So we're gonna have a break. Please visit our exhibitors. We are back at 10:25 for the breast cancer and melanoma session.